Hello and welcome back. I'm Professor Adam Thompson. In this video, we're going to talk about the pre-hospital response to the bleeding patient. Of course, we start with our scene size up. And once your scene is deemed safe, you're going to take your standard precautions, your gloves, whatever extrication gear you might need, all of that stuff. And keep in mind that a high energy mechanism of injury should increase your suspicion of possible internal hemorrhage or internal bleeding. And internal bleeding, of course, can also be caused by any illness. And if they have illnesses such as hemophilia, the bleeding could be even worse, or if they're on anticoagulants, so on and so forth. Attempt to determine the amount of blood that's been lost. Remember, the presentation and the patient assessment should direct your patient care. And if there's a significant mechanism of injury, the scene time should not exceed 10 minutes. Remember, we want to limit the amount of scene time in case this patient needs emergent surgery. So doing your primary survey, you're going to want to determine the patient's mental status using your AVPU scale. Are they alert? Do they respond only to verbal or painful stimuli, or are they completely unresponsive? Locate and manage immediate threats to life involving any airway, breathing, or circulation issues. Again, if they have a major hemorrhage, start with C and control the hemorrhaging before you go ahead and count the respirations and do all of that, because airway and breathing are useless if there's no blood in the body. Manage any major external hemorrhage immediately. Treat for shock and transport to the emergency department. Direct pressure and pressure dressing can manage most external hemorrhages. However, tourniquets can effectively control hemorrhage not responsive to direct pressure and a pressure bandage. Evidence supports hemostatic agent use for external bleeding. Of course, you're going to want to consult your local protocols, but your quick clot type of bandage that started use in the military, it's shown to really be helpful with external hemorrhaging. Studies are also examining tranexamic acid, which is TXA, okay? And that is a medication that can be used to actually help control internal hemorrhaging. It's been used for a while for postpartum hemorrhaging, and it works really well with that. And it's been used in the military arena and now pre-hospitally to help control bleeding as well. Continuing on with your primary survey, a patient with internal hemorrhage needs rapid transport to the emergency department. They need surgery usually, right? So that can't happen pre-hospitally. He needs to get to the hospital for that to happen, to the operating room. Tachycardia is an early sign of hypoperfusion, suggesting that there is some sort of internal hemorrhage. Late signs suggesting internal hemorrhage include weakness, fainting, dizziness at rest. They could have thirst, nausea, vomiting, cold, moist skin, shallow, rapid respirations. They might have some dull eyes with slightly dilated pupils that are slow to respond. They become sluggish pupils. Capillary refill of more than 2 seconds in infants and children is also a later sign of poor perfusion, and a weak, rapid pulse, decreasing blood pressure, and then an altered level of consciousness. Remember, when somebody has an altered level of consciousness, you're thinking decompensated shock. If internal hemorrhage is suspected, don't forget to keep that patient warm, right? We want to fight off that trauma triad of death by keeping the patient warm. We don't want increased coagulopathy due to hypothermia and acidosis. Administer supplemental oxygen by non-rebreather mask while en route to the hospital, if indicated. If there's minor external hemorrhage, make note and complete the assessment. If you're assessing your patient and you come across some minor hemorrhaging, continue your assessment and make a mental note. Manage that minor hemorrhage after the patient has been properly prioritized and other types of hemorrhaging have been managed. When a patient has signs and symptoms of shock, but only minor visible bleeding, remember to consider that there is potentially some significant internal bleeding that's actually occurring. When you're taking the history, investigate the chief complaint and obtain the history of the present illness. You're going to want to ask about dizziness or syncope, what medications that they might be on that may thin the blood. Remember your anticoagulants, antiplatelets. History of clotting insufficiency, such as hemophilia. The use of beta blockers, right? Calcium channel blockers, antidysrhythmic, or nitroglycerin. All of those medications can actually hinder the compensatory process. You might have somebody that's in hypovolemic shock, but they don't have the tachycardia that you're used to seeing. See if they're on a beta blocker or one of these other medications. Any pain, tenderness, bruising, guarding, or swelling also may indicate some internal hemorrhaging as well. Moving on to your secondary assessment, you're going to want to perform a systematic full body scan. Symptoms of internal hemorrhage often include pain and swelling. Contusion or ecchymosis may also be a sign. Your only initial sign of pelvic or abdominal trauma may be some redness or skin abrasions or even some pain. Bleeding in the chest may cause dyspnea or tachycardia or even hypotension, of course. And hemorrhage from any body opening usually indicates internal hemorrhage, right? If somebody's bleeding, if they're vomiting up blood, or if they're, passing blood with their stool, all of these things indicate internal hemorrhage. Signs of serious internal disease or injury may include bright red bleeding from the mouth or the rectum, hematuria, which is blood in your urine, non-menstrual vaginal hemorrhage. This could be an ruptured ectopic pregnancy, which is a very serious condition. Note that bleeding characteristics and try to determine the source of the bleeding. Other signs and symptoms of internal hemorrhage include hematoma, right, which is that swelling you see under the skin from the pooling of blood. Hematemesis, which is when they're vomiting up blood. Hemoptysis is not hematemesis. That's different. Hemoptysis is when they're coughing up blood, right? That's often seen with a tuberculosis patient or a lung cancer patient. Melena, when you have blood in your stool. Hematuria, blood in your urine. Hematochezia, also another type of blood in the stool. Typically, that's a more brighter red blood. Pain, tenderness, bruising, guarding, or swelling are all different types of signs that you might see with internal bleeding. Broken ribs, bruises over the lower part of the chest, or rigid, distended abdomen. Remember, rigid, distended abdomens mean there might be blood inside of it. It may indicate a lacerated spleen or a liver. May also have referred pain to the right shoulder, which could be the liver, or the left shoulder, which could be the spleen. And suspect internal abdominal bleeding in a patient with referred pain, which is what we were just talking about, referred pain to either the left or the right shoulder. Assess the respiratory system. You're going to want to check the airway for patency, determine the rate and the quality of respirations, and check for distended neck veins and deviated trachea. Check for paradoxical chest movement and bilateral breath sounds. Remember, paradoxical chest movement is when the chest moves in opposite directions. Assess cardiovascular system, the rate and the quality of your pulse. Your pulse oximeter may be inaccurate for patients in shock. Remember, you need perfusion to your distal portions of your finger for it to actually be an accurate pulse oximetry reading. Use an ECG monitor for the cardiac rhythm, and pulses are related to the perfusion status. So as blood pressure begins to drop, pulses disappear. Blood pressure appears normal in early stages of shock. Medications may mask vital sign changes. We were talking about that before with your beta blockers, calcium channel blockers, your nitroglycerin. So your beta blockers can interfere with your sympathetic compensatory response. Your calcium channel blockers will interfere with your vasoconstriction as well as nitroglycerin. And other antidysrhythmics will interfere with the heart's ability to speed up or to pump with more force when your sympathetic nervous system is trying to kick in that compensatory response. So any of those medications can kind of, numb that response, so to speak. Patient will often present with pale, cool, mottled skin when they're bleeding, decreased or absent radial pulses, another sign of shock, and the increased capillary refill time. Remember, your capillary refill should be brisk. It should be really fast, less than 2 seconds. This is a very good vital sign in children. And when you see it take longer than 2 seconds, it's a pretty accurate sign of really poor perfusion. Assess neurologic system. And make sure your exam includes, examining the level of consciousness, the pupil size and the reactivity of the pupil, your motor response, your sensory response. A trauma patient with an elevated blood pressure and a slow pulse may still be in shock, but in the presence of a head injury, the patient may be experiencing what's called Cushing reflex, owing to an increasing intracranial pressure, right? So you could have a Cushing reflex due to increased intracranial pressure, which can actually decrease your patient's heart rate, increase their blood pressure, but they do have a significant type of shock. Remember to assess the musculoskeletal system as well, and assess the anatomic regions. While examining the head, look for raccoon eyes, which is periorbital ecchymosis or bruising around the eyes, or Battle's sign, which is postocular ecchymosis or bruising behind the ear. Both of these are signs of a basilar skull fracture. Drainage of blood or fluid from the ears or nose. This could include cerebral spinal fluid, could be a sign of a very significant head injury. While checking the abdomen, feel all 4 quadrants for tenderness and rigidity. And then in extremities, record the pulse and the motor and the sensory function. And if the patient has bleeding from the extremities, note the level of the bleeding and whether the bleeding is arterial, venous, or pulsing. You know, that pulsing type of bleeding tends to be more arterial and more severe. With reassessment, you're going to want to definitely reassess, especially where abnormal findings were found during the primary assessment, and then reassess interventions for controlling hemorrhage to ensure that they are actually adequate. So every time you control some bleeding, reassess the patient's vital signs. And in cases of severe hemorrhage, obtain vital signs every 5 minutes while en route to the emergency department, and get this patient to the right facility to get the right treatment. That is part of the care as well. And with that, that ends this video on managing bleeding.